Jeremy is a child psychiatrist and neuroscientist who works at both Columbia University and the Center for Autism and the Developing Brain in White Plains, New York. As a clinician, he consults with families weighing decisions about whether or not to start medication for their young children with autism, and also consults with older children and adults for whom a variety of treatments have offered little relief. His clinical research program tests potential treatments for autism and related genetic syndromes. His molecular research program examines systems in the brain related to social and repetitive behaviors. The overarching goal of his work is to deliver new treatment options that better the lives of people with autism. It is our extreme pleasure to have Jeremy with us today, so without further ado, Jeremy, please take it away.
Thank you so much, Amy. Thank you also to Vincent, as well as Pam Feliciano, who provided very useful input as I was putting this together. I think I initially had a little bit too ambitious of a plan to essentially cover everything related to autism treatment. So you'll note that my starting slide now is medications in autism, which is really where I'm going to focus. As a child and adolescent psychiatrist, I'm often asked to provide an opinion or guidance regarding whether medicine should or should not be used. It certainly isn't the only thing I provide recommendations on, but it, I think, fits as a useful topic for this webinar. Before I start, I also want to say thank you for participating in Spark. I obviously care for children and families in my clinical practice, but I also spend a lot of my time doing research, in large part because I'm unsatisfied by the treatments that we can offer at this point. And really, by participating in Spark, you're part of the larger effort to generate new understanding and ideally new treatments down the line. So before I start, I want to acknowledge I've had funding from a variety of sources, and including in that is funding from pharmaceutical companies. I think it's important to know that, unfortunately, none of this funding, none of the studies we've participated in have yet yielded a treatment that I'm going to be talking about today. So it's the specific funding is more or less irrelevant. I think it'd be interesting at some point to talk about why it is that pharmaceutical companies get engaged in autism treatment research. Maybe a topic for another day. Let me see. There we go. So I'm very briefly going to talk about autism spectrum disorder and how we formulate autism spectrum disorder as clinicians, then talk about what we know about medications in autism spectrum disorder, really emphasizing what we know with significant confidence, as opposed to ideas that people might have. I'm then going to pause for any questions that people might have at that point, and then move forward to talk about common co-occurring psychiatric conditions in autism spectrum disorder, and finally spend a very short period of time on the ultimate goal, which is really to put medication treatments together with behavioral treatments, so that we ideally put the brain in a position where it's better able to learn, and then couple that with what we know on the behavioral side. Sorry, for whatever reason it's not advancing when I just push the arrow, but we'll make it through. So when we think about autism spectrum disorder as clinicians, we generally speaking don't think of it as a disease. So we don't think of it like something such as, ductal breast cancer, where you know what the disease is, you know what the particular treatments are associated with that. Instead, the way I think about autism spectrum disorder is a description of the problems a particular child is having that do fit within a category, and that category does guide treatment. But that doesn't mean that we understand the causes of autism spectrum disorder symptoms for an individual child. So in this figure you see up here on the right, some of the significant risk factors that have emerged on the genetic side in autism spectrum disorder, and that's one of the things that Spark is doing to generate a better understanding of those risk factors, and ideally better understanding of subgroups that may share risk factors. On the bottom right, you see biomarkers. There are any number of these. You hear about these pretty frequently if you follow the autism research news. And unfortunately, while those are probably going to give us clues over time that will guide treatment, at this point, really those are things that are useful in research studies only. Medical comorbidities are incredibly important to pick up in autism spectrum disorder. That's generally where you want to start as a clinician, making sure that if a child has a seizure disorder that you're catching it and treating it appropriately. And then other medical conditions that can cause significant distress, like constipation, are things that should be addressed. We used to lump language impairment in with autism spectrum disorder. We now understand that it's separate and requires separate treatment. And then intellectual disability is quite common in autism spectrum disorder. Today what we're mostly going to be focusing on are treatments along this edge, so treatments for co-occurring psychiatric conditions or behavioral difficulties. But I think it's important to stress that when we test a treatment and say it's a treatment in autism spectrum disorder, we're testing that in a broad group of individuals who may have some things in common, obviously, but also have differences. So individuals who may fit this pattern, individuals who may fit this pattern. In the end, I think we're going to find that these folks have different underlying risk factors, likely different neurobiology, and at this point we're unable to separate those things. When we do have treatments focused on the edges, we may have areas where perhaps behaviors have more in common and may allow us focused treatments. So that's really all I'm going to say in terms of background, and then really focus on what we know about medications in autism spectrum disorder. So this really comes from work I did back several years ago when I was at Vanderbilt University working with the Evidence-Based Practice Center there. We performed a systematic review of effectiveness of therapies in children and then later followed that up in adolescents and adults. We were looking not for how much of an impact a given treatment might have, but really the strength of evidence that we had based on the overall research literature showing that there is an impact of a given treatment in autism. So that importantly is not the degree of benefit, it really is the strength of evidence, the amount of evidence that has accrued. We looked at behavioral interventions, and this is not where I'm going to be spending most of my time, but this is where most children, adolescents, and adults with autism spectrum disorder should be spending most of their time. So what is quite clear is that early and intensive behavioral and developmental interventions can make an impact on cognitive, language, and adaptive behavior outcomes, certainly for a significant number of individuals with autism spectrum disorder. It's also clear that targeted cognitive behavioral therapy for anxiety symptoms also leads to benefit, primarily for higher functioning verbal folks with autism and co-occurring anxiety. And then there's also evidence for social skills training. That's all the time I'm going to spend today talking about behavioral treatments, but importantly, again, that is where we think most of the benefit should lie for an individual child. When we start talking about medicines, it's important to first say that there are no medications that we know help with the core symptoms of autism spectrum disorder. So really we're talking about medications along that edge for co-occurring behavioral problems, including problems that can be diagnosed. So as most of you know, that there are two medications that are approved by the Food and Drug Administration for use in autism spectrum disorder. They are aripiprazole and risperidone. These are medicines that are not approved for autism or for core symptoms. Instead, the description by the FDA is that they're approved for irritability. Irritability, as defined in the studies that were used to demonstrate that these medicines are helpful, came from a checklist that was originally, that had a subscale originally described as irritability, agitation, and crying. So we're not talking about irritability like you're grumpy because you didn't get your coffee in the morning. Really, we're talking about irritability that leads to agitation, that leads to aggression or self-injury. We're talking about the sort of irritability that leads to children being excluded from certain educational settings, not being able to tolerate being out in public, this sort of irritability and agitation. In those studies, you also saw improvement in hyperactivity and stereotype behavior, but importantly, these were not the treatment targets, and these seemed to be improvements that came along for the ride. But the individuals who were treated in these studies really had significant agitation, usually aggression and self-injury coming in. So this is the sort of result that was seen in these studies. On the bottom here, you see the number of weeks in the study, and then on the side here, you see the number or percentage of individuals who are rated as much improved or very much improved by the clinicians who are seeing them. So if you're looking at this time frame, you see by 3 weeks, roughly half of individuals in the risperidone group showed significant improvement as rated by clinicians, and very few in the placebo group. In subsequent studies, placebo response rates have gone up, and we'll talk about that a little bit later. But you see it isn't every child who shows significant improvement. By 8 weeks, it's roughly 3 in 4 who show significant improvement in this study of risperidone. So that's really good news. On the other hand, these medicines are associated with significant side effects. The biggest one that really concerns almost every family is weight gain due to increased appetite. Sedation is also seen, usually wears off over time, but not always, and then a risk of motor symptoms over time. Briefly, I'm just going to mention a recent study that showed that a medicine usually used for diabetes, metformin, leads to a cessation of weight gain in children who are taking these sorts of medicines without having a significant difference in side effects, although I would note, having been involved in this study, that we did see that overall there were more days with gastrointestinal side effects, mostly diarrhea, sometimes gas. Those side effects seem to improve over time. But this slide is really why I'm showing you this study. On the top, you see the primary outcome measure we used, which was corrected for expected growth over time. But here is the easier graph to understand. Over 16 weeks of treatment, so 4 months of treatment, this is weight change from baseline. You see initially both the active treated group in the solid line and the dashed group, which is the placebo group, show an initial increase in weight that then levels off in the group that's receiving the active medicine, showing that this treatment with metformin is able to stop weight gain on these medicines, the aripiprazole, risperidone, and other medicines in that class. Important when we think about using these medicines, because you can see this trajectory. In only 4 months, you see a weight gain of almost 3 kilograms, and you can imagine over time that's going to sum up to dozens of pounds of weight gain, risk of diabetes, risk of other health problems that have been described with these medicines. So that's that class of medicines. There's another class of medicines that have been tested for ADHD symptoms. With a change in autism diagnosis, there's also been a change in diagnosis of co-occurring psychiatric conditions in autism. And now you can make a diagnosis of attention deficit hyperactivity disorder in the context of autism. When I talk with families about our evidence in this domain, I talk about the law of 50%, and I'll illustrate that over time. So methylphenidate, brand name Ritalin or Concerta, is one of the medicines that's been reasonably well studied for ADHD symptoms in autism spectrum disorder. And here you see the beginning of the law of 50%. 49% of children with autism spectrum disorder and ADHD symptoms show a much or very much improved rating after treatment, as well as 30% symptom reduction. So 50% improve. Almost 20% can't even tolerate the lowest dose of methylphenidate due to side effects, primarily due to worsening irritability, not something we want to see. And then obviously another 30% don't see significant improvement with these medicines. And some of that is also due to dose limitations due to side effects. So when we turn to another medicine, atomoxetine or Strattera, different mechanism of action, the initial study, large study, did show what was described as significant differences in the active treated group versus placebo, but only 21% of individuals were rated as very much or much improved, and 9% showed significant improvement on placebo, not the sort of medicine that we usually like to turn to. And then a follow-up study that used a higher dose and split that dosing into twice a day instead of once a day actually showed that same nearly 50% group with much improved ratings, a little bit higher improvement on placebo than in the previous study, and no additional advantage of parent training in comparison to atomoxetine or Strattera alone. Side effects are quite limited, really just decreased appetite. And not in most individuals. And then the last medicine that's been adequately tested, guanfacine, showed similarly about a 50% improvement across 8 weeks of treatment. and a low response to placebo. This did show a little more side effects than the atomoxetine or Strattera, with sedation, decreased appetite, and dry mouth, but it was overall well tolerated, much better tolerated than the methylphenidate. And then turning to repetitive behavior symptoms, and this is obviously a diagnostic domain of autism spectrum disorder, but I'll explain why it is that we don't think of medicines in this area as either being helpful or as necessarily addressing core diagnostic features. So serotonin reuptake inhibitors are the classic medication treatment for obsessive compulsive disorder, and for that reason a lot of clinicians expected that these medicines would be helpful in autism spectrum disorder. And unfortunately, a large trial of citalopram, one of the medicines in this class, as well as an unpublished trial of fluoxetine or Prozac, showed no significant benefit when all the repetitive behaviors of autism are lumped together. In a follow-up study, the authors of the initial study found differential response to placebo in children who were less affected, so children who were less distressed, who had less disruptive behavior or family disruption as a result of their repetitive behavior, actually improved more on placebo than they did on citalopram, which is really not what you want to see in one of these studies. Importantly, in these studies, you saw significant activation symptoms in a large portion of children with autism spectrum disorder. Again, these are not the sort of things that we want to cause with medicine. What was seen was increased energy, decreased need for sleep, impulsivity, mood changes. These are the sorts of things that led to decreases in the dose of medicine used in these studies, which may have limited the ability to see benefit. In contrast, in adults, there have been a couple of studies that have shown significant improvement. And what you see on the right here is improvement in a scale used to measure obsessive-compulsive symptoms, so not just repetitive behaviors all lumped together, but now really OCD symptoms. And you see in the active treated group in red here a significant improvement over time, and no significant improvement in the placebo group. And here you see the individual level improvements. Importantly, these are in higher functioning individuals with a mean IQ just above 100. And in these adults, and similar data for another medicine, much less activation was seen, suggesting that these medicines may just be better tolerated in adults. So that's really what we know in the positive direction, but actually the medicine that's been best studied in autism spectrum disorder is a medicine that we now know quite conclusively does nothing of any use. So this is Secretin. This was quite popular as a potential treatment now about 15 to 20 years ago, and then 7 randomized controlled, placebo-controlled trials were done, and each showed really no benefit for treatment with Secretin in comparison with the placebo. This despite the fact that tens of thousands of kids in this country took Secretin as an IV infusion for the most part. This may offer us a sobering parallel to treatment fads that seem to emerge in autism spectrum disorder every few years. One of the ones currently would be transfusion with stem cells, either derived from cord blood or otherwise. We don't know yet whether this is something that's helpful. The Secretin fad was begun in part based on open label and case series data, so families seeing significant improvements in their children using developmental measures after receiving Secretin. But really it's important in these sorts of studies to compare against placebo, and it isn't always that there is just a placebo effect, that the placebo is having some effect or that belief has some effect. But development continues even if a child has a developmental disorder, and oftentimes unless we compare against placebo, we're unable to adequately control for the effects of development. And this slide shows one example from the Secretin literature, where you see actually in this line the effects in the active treated group, the group that received Secretin, and in this line here you see the group that received placebo. On the left here is a total score using an autism behavior checklist, just one of several outcome measures that could be used and were used actually in this study. None of them showed an advantage of Secretin over placebo, and here you see an improvement that's actually larger in the placebo group. Obviously, again, not what we'd like to see. But what's perhaps most sobering is that, and now this is almost 20 years ago, where we don't have treatments that have evidence behind them, oftentimes, understandably, families pursue treatments that don't have a lot of evidence behind them. Secretin actually, I would say, leads to distress and actually harm because it requires an injection. But here you can see that families, even after seeing the results of the study, still had some interest in Secretin as a potential potential treatment. So I think it's important to pause here and note that many of the current medical treatments that are talked about in the press, talked about in the community, have similar evidence to what Secretin had before the randomized placebo-controlled trials. And that really should give us pause about what we should expect to see if these treatments are adequately studied. And I'd like to pause here for about 5 or 6 minutes to just take some initial questions. And I can look at the questions on the left, although I realize, Vincent, I think you said you also could highlight particular questions that you wanted to bring forward.
Yeah, I can read them aloud to you. So you kind of covered this, but we had a question about if there are medications to decrease sensory sensitivities, and would you recommend them?
So we don't have data to suggest that there are medicines that decrease sensory sensitivities. In some of the studies that have been done, sensory sensitivities are captured within subscales. So sometimes those land in the repetitive behavior subscale. Oddly enough, sensory and repetitive behaviors tend to go together. So there is a little bit of data in the literature on risperidone and aripiprazole that may address that, but not very directly. And certainly I wouldn't look to medicine specifically to address sensory sensitivities. I would only think about a medicine in the case that a child had significant distressing behaviors, distressing to the child, distressing to the family, limiting their access to educational or other environments, and then might think about a medicine for that. In contrast, there are behavioral approaches to sensory sensitivities, and I think that's important to highlight. Those mostly use desensitization sorts of approaches. Sometimes that's done by a board-certified behavior analyst, sometimes by an occupational therapist.
Okay. You mentioned the study at Duke with umbilical cord blood. Would you be able to elaborate any more, or is there just not enough information yet on the results?
Sure. So what was initially described, and I think quite responsibly, but then sometimes these things get carried forward in the press. But what was initially described was improvement over time after receiving cord blood infusions. And I think that that's potentially exciting for further research studies. But that would be similar to what I showed, and let me go back to it. So if we didn't have a placebo group here, if we just had the Secretin treated group, that looks like improvement over time. That looks like the sort of treatment that you might want to use. But then when you look at the placebo group next to it, so this is receiving an infusion of nothing, you realize that this sort of improvement actually is probably what would be seen without any treatment at all. And what we don't yet know for the cord blood treatment is whether it will be larger than the improvement that will be seen over time in a placebo group. And the investigators at Duke were very responsible about saying we really need placebo-controlled studies before we can judge these outcomes. Obviously, if you do this sort of a study and you see just a flat line, it doesn't matter if you have a placebo control group or not. That's the sort of thing that you wouldn't want to use. But the truth is we very rarely have that in open label treatment in autism spectrum disorder, particularly when you're looking at developmental outcomes, because development continues whether or not you have a developmental disorder. And that actually is, I would say, a hopeful thing. But it really means that we have to have adequate control in order to feel like we're doing something that is evidence-based.
Okay. Do you have any more information about any studies on Adderall?
So, Oddly enough, there have not been placebo-controlled studies of Adderall or related medicines. So Adderall really is mixed amphetamine salts. It contains 2 different amphetamines. That doesn't mean Adderall doesn't work. It probably means that because Adderall is off patent, pharmaceutical companies haven't been motivated to study Adderall. In my own practice, I've observed in kids with ADHD that the response to Adderall is pretty similar clinically to the response to methylphenidate. I almost always start with methylphenidate because we have direct evidence, but you can see in the literature pertaining to ADHD without autism spectrum disorder that the response rate and the benefit seen is almost identical for mixed amphetamine salts or Adderall or Vyvanse or other amphetamine derivatives in comparison to methylphenidate.
Okay, maybe we'll just do one more question and then we can continue on. Do you have any recommendations about when to start using medication? Is there a time that would be too early? Is it sort of on an individual basis?
So it really is on an individual basis. I look for where you can make a very clear and convincing co-occurring diagnosis. So if you're thinking about a medicine for ADHD, you should be able to make a diagnosis of ADHD. If, on the other hand, you can't tell whether a child is not paying attention because they're not able to follow what's happening in the classroom, or maybe engaging in repetitive behavior that's driving their hyperactivity, that's a time when I would hesitate to start a medicine that really is for ADHD occurring in autism spectrum disorder. When we're talking about irritability and agitation symptoms, there I really ask myself 3 questions. So the first question is the child hurting themselves? And not just hurting themselves a little bit, but getting hurt or likely to get hurt. And then is the child harming somebody else? Those 2 questions would extend to unintentional behaviors or elopement. A child who might be jumping out of windows, climbing on things, that's a situation where a child might be at risk. And then the third question is a child losing access to an educational or behavioral setting where they might otherwise benefit? So is a child not able to go into a classroom setting because of their disruptive behavior due to irritability and agitation? So I ask myself those 3 questions, and when the answer is yes, then we talk about what the options might be. We always also think about behavioral interventions as a first line. And that'll actually come up as we're talking about the next section. So let me move forward to talking about how we approach common co-occurring psychiatric conditions in the context of autism spectrum disorder. And here I've said this in a number of different ways, I think, but this just states it clearly. So most children with autism spectrum disorder either do not need or will not benefit from available medications. However, I think it's important to note that by the time they hit adolescence, most children with autism spectrum disorder have already been prescribed a medicine. So in that context, I think it's important to note that there are lots of targets we could be talking about today. I've highlighted that we really should be starting by thinking about medical comorbidity, where we think about core symptoms or communication. We're not talking about medicines. I think it's important to note that having a child with an autism spectrum disorder is by itself a dramatic stressor on a family, but also other stressors happening in the family life, in the child's life, can lead to behavioral difficulties and should be addressed, just like they'd be addressed in another family. And finally, we think about co-occurring psychiatric conditions. When I'm talking about treating children with autism spectrum disorder to clinicians, these are the sorts of principles I walk through, but I think it's useful for families to hear as well. It should not be the case that a clinician is saying, your child needs X, here's the prescription. Instead, this is a decision that should be made in a partnership, parent, child where appropriate, and clinician. When we're thinking about medicines, we really have to think about the oath that we take as clinicians. So first, do no harm. In my world, that includes avoiding chronic responses to an acute problem. So if a child has a sudden surge in aggression, wasn't aggressive before, has been aggressive over the last 3 days, we don't want to prescribe a medicine that child is going to take for the rest of their life. Obviously, we want to figure out what's driving the aggression. Often this is something simple. So does the child have an ear infection? Could that be driving the aggression? Let's treat that with something other than a medicine targeting behavior. We always want to be overtly managing benefits and risks or side effects associated with the medicine. We always want to also aim for the least restrictive environment. In my world, that means avoid hospitalization if possible. Hospitalization is oftentimes destabilizing. We want to have a clear conversation where we articulate a symptom that a medicine might benefit. We want to target that. We want to follow it up. We don't want to think about general benefits. We want to be very focused and specific. Where we're starting medicines, we want to start low, lower than we would outside of an ASD population, and we want to go slow. We want to make slow increases and measure whether we're seeing benefit. Importantly, we want to follow up within expected response periods. So I showed you that for risperidone, we should be able to titrate the medicine up and see whether we're seeing a response over the course of roughly 8 weeks. So you don't want to prescribe risperidone and then return to talk with a clinician 6 months later. That just makes no sense. You also don't want to talk a week later before we can tell whether something is going to lead to improvement. We want to, whenever possible, change one thing at a time so that we can tell what it's doing. This means you don't start a medicine at the same time as you're starting in a new classroom setting. It also means that you don't start 2 medicines at once, if at all possible. You want to maximize response to one treatment before adding another. So I try not to start, say, methylphenidate, work up to a suboptimal dose, and then also start another medicine for ADHD. Instead, let's see what we can get out of one treatment before adding another. And then finally, we want to monitor side effects as closely as benefits. So when we're talking about starting risperidone, for example, I always talk with families about what would make us stop and what would make me want to hear from a family. So if a child is gaining 10 pounds in the first 2 months, that's a medicine we want to stop. But unless we have that conversation at the front end, we may not really know what we're looking for. Very frequently, the reason a family comes in to see me is nonspecific. So that would include cases where a child is coming in with irritability, agitation, or frequently the presenting complaint is aggression. When we're looking at that sort of a presentation, we're really thinking in this way, sort of going through that cascade I shared earlier. So thinking about stressors that may trigger these behaviors, think about medical or sleep problems that could be leading to difficulties, improving communication. If I can't communicate, you bet I'm irritable. You bet I might hit somebody instead of communicating with them with the words I can't use. We want to use ABA approaches whenever possible, and then we want to think about whether we can make a co-occurring psychiatric diagnosis that may be driving the irritability and agitation. So we're going to come back to that general category and first talk about co-occurring psychiatric diagnoses that can be made. So ADHD, I talked about the evidence. Now I want to talk about what we actually do. So again, first we're thinking about sleep or medical problems that could be the trigger. Frequently, kids who don't sleep well are inattentive during the day and hyperactive during the day. A lot of us know this when we have infants. If they don't sleep well, they're irritable, they're hyperactive, they don't necessarily sleep. They may just be incredibly distractible during the day. You also want to rule out seizures. This doesn't require an EEG. It just requires a careful history most of the time as a cause of inattention. So if a child has staring spells, we want to make sure they're not having seizures. We want to make sure that the inattention isn't just happening during a depressive episode and that the hyperactivity isn't restlessness driven by anxiety. We then want to evaluate the setting in which it's happening. So is the child inattentive because they don't understand what's being said to them? Is the child distractible because they don't know what's going to happen next? Can the child be helped by having predictable reinforcers that allow them to better attend and avoid distractibility? When we do turn to medicine, I usually turn first to guanfacine. The reason for that is that the side effects tend to be lower than with the stimulants like methylphenidate, and that the benefit tends to be bigger than with atomoxetine. So this is explicitly the balance I was talking about, potential benefit, potential risk. Sometimes I don't start there because I'm worried about sedation, or because I have a child who may be older, may be higher functioning, who may be more likely to benefit from methylphenidate, which is more likely to help with inattentive symptoms. So this is a balance. These are conversations to have with a clinician. But these are the medicines I told you about as having significant evidence. And this is the balance that we use. We do occasionally turn to risperidone or aripiprazole or related medicines in this context, but only when we're talking about severe impulsivity. So I've worked with kids who will be so hyperactive that they cannot be constrained in a car seat, may try to elope from a moving car, may have jumped out of a window, may not be able to stay in the house unless the door is locked. In those conditions, if we're unable to manage that behavior with other medicines, sometimes we do turn to these, but only in those conditions. When we're thinking about anxiety, it's important to differentiate typical anxiety that can be related to ASD. And I think of this in the context of not knowing what's going to happen in the environment, not being able to predict their world. And in that context, oftentimes you do see anxiety, but you don't necessarily see a diagnosis. So only in those situations where we can make a diagnosis of an anxiety disorder do I really think about medicines for anxiety. This can mean separation anxiety disorder, generalized anxiety disorder, social anxiety disorder, and here we're not just talking about sort of abstract ASD-related anxiety in complex social situations. You're really talking about defined phobia. This is a hard diagnosis to make, something to discuss with a clinician. And then in teens or adults, panic disorder, which can be missed in folks with autism spectrum disorder, particularly when they're unable to express their experience. When we're thinking about a pathway for anxiety treatment, again, we start with behavioral and educational approaches, social stories, making the world more predictable, using communication tools to express what somebody's experiencing, but also to take in information from the outside, and having a predictable structure. I told you at the very beginning there is evidence for cognitive behavioral therapy. Essentially, this is like systematic desensitization approaches or exposure and response prevention, going into anxiety-provoking settings, learning tools to cope with the anxiety related to those settings. This is quite effective for kids who can talk through some of their anxiety, less effective for kids who can't. And then when we do think about medicine in this context, it's really something to talk in detail with a clinician about, but we're talking about medicines usually that have a shorter duration of action, a shorter half-life. What we talk about clinically, these are medicines like sertraline or Zoloft, medicines that quickly clear the system so that if you do see those activation side effects I talked about, they don't last for a week, they last for a day. In the repetitive behavior domain, we're talking about this sort of area where it is necessary to make a diagnosis and seen in every individual. But where we can make a co-occurring diagnosis of obsessive compulsive disorder, it's more reasonable to start thinking about medicines. So treatment in this domain, usually we're thinking about ABA-based treatment where you're differentially reinforcing other behavior that may not be the repetitive behavior that's interfering on a daily basis. If a child is higher functioning, can talk through some of their experience, you can use cognitive behavioral approaches pretty similar to the approaches I talked about earlier with anxiety disorders, with exposure and response prevention. If you can make a diagnosis of OCD, we know in adults that medicines like fluoxetine or Prozac, medicines like fluvoxamine or Luvox can be helpful. In children, I will sometimes still use medicines like sertraline or Zoloft, although acknowledging our data aren't great in children, but I have had some success, and sometimes you reach for a medicine after other things have failed. And then there is some data outside of autism spectrum disorder that for simple repetitive behaviors like skin picking or hair pulling, a medicine that's really a supplement called N-acetylcysteine can be helpful. I will also sometimes reach for that for repetitive self-injury, kids who hit themselves in a repetitive way, for example, not just when they're distressed, kids who bite themselves, behaviors like that. And now turning to an unfortunately common diagnosis where there's essentially no data on treatment in autism spectrum disorder. Depression is quite common in adolescents with autism spectrum disorder who are more verbal, who can relate to, engage with their peers, but particularly in that time frame where most adolescents are shifting from an orientation toward family to an orientation toward peers, we frequently see the emergence of depression, and we see it with less of a female bias than in the general population. So in the general population, depression is more commonly recognized, at least in young women. In autism spectrum disorder, we see it nearly as commonly in young men. As I said, there's almost nothing known about treatment. So what do? Well, we adapt what we know outside of the autism literature, as well as what we know improves behavior in autism. So outside of the ASD literature, we know that behavioral activation, so spending more time doing things that give a sense of pleasure or things that give a sense of accomplishment, and I've seen that be effective, although without a good control group, in individuals with autism spectrum disorder. Similarly, using more structure to have better defined activities, less unstructured time seems to be helpful for some individuals. And then you can use cognitive behavioral or other therapy approaches for folks who can talk through what they're experiencing. I will also turn to serotonin reuptake inhibitors in this population. So in adolescents, we know that fluoxetine or Prozac helps with depression. We know that not all these medicines are as helpful. In autism spectrum disorder, we just don't have data to guide us, but it's not unreasonable where you have a case where a child is experiencing intractable depression to turn to one of these medicines and hope to see benefit. There are other medicine options that have been shown to be helpful in adults without autism spectrum disorder. Those aren't unreasonable to try either, but it's important to recognize that we're adapting those and important to really think about these sorts of treatments in partnership with a clinician. I'm not covering insomnia today, but that's a big topic. It's a topic for another day, certainly a time that we do think about medicines. When other approaches are not helpful, and we still are dealing with irritability, agitation, or aggression symptoms, then we do think about medicines without having a specific diagnosis outside of autism spectrum disorder. So I usually first think about guanfacine or clonidine. I told you earlier we know guanfacine is helpful for hyperactivity and impulsivity symptoms. So why do I think about it first? For irritability and agitation symptoms, it's because it can help with impulsivity, and sometimes even in the absence of an ADHD diagnosis, impulsivity is really driving the agitation symptoms, and so I think about it first. And then I think about risperidone or aripiprazole. There is some but not abundant evidence for an older medicine, haloperidol, that I'll sometimes think about as a backup if these medicines don't work. And then these medicines are in a family that includes other medicines that are not unreasonable to think about but don't have specific evidence in autism spectrum disorder. So I've walked through most of my outline. I just want to say one more thing, which is that we almost never are delivering in the real world a medication without behavioral treatment, and frequently behavioral treatments are administered in the context of medication. And there's really only one study that shows added benefit for using medicine plus behavioral treatment, and that's a study from the RUP group with Mike Amon as the first author. This is showing two groups here in blue and in pink, both of whom were receiving risperidone. And the group in blue was receiving a parent-administered behavioral intervention on top of the risperidone. You can see at the end of 20 weeks of treatment with both risperidone and the behavioral treatment, you see a significant difference between the groups. There is a gap, but that gap isn't very big in comparison to the improvement that was seen with risperidone alone, and there was no placebo group in this study. So there is added benefit here. When these folks were followed out another 6 months, there was no longer a significant difference, but it's worth noting that the group receiving the behavioral treatment was receiving a lower dose of risperidone because clinicians recognized that they were improving faster when they were also receiving the behavioral intervention. And this illustrates some of the challenge in studying treatments administered together, but I think also is the sort of study that we'll need moving forward to look at the combination of behavioral treatments that we know are effective, and this particular behavioral treatment has now been studied without risperidone and does lead to significant benefit. But obviously we don't want to just use medicines. We'd want to leverage medicines ideally, again, as I said earlier, to put the brain in a better place to benefit from behavioral interventions. This is my summary, which I don't need to read to you, but I think it's important to note that I first outlined evidence, and then I outlined some of the real-world treatment. I'm sure folks listening, watching today have seen other medicines be used in the context of autism spectrum disorder, maybe for your child. That doesn't mean those are unreasonable things to do. It just means usually that means that clinicians are reaching for a medicine that may be related to something where we do have better evidence, or maybe things that have worked outside of ASD and are being adapted to use within autism spectrum disorder. Those are reasonable things to do, but obviously need to be done in partnership with a family that has to make these difficult decisions. So now I'm going to turn back to questions and hand things back over to Vincent.
All right, thank you so much. So we'll just jump right in. Can genetic insights help in determining what kinds of medications to use?
So at this point, not really. I would say there are some emerging areas in epilepsy where there are genetic findings that point to a particular medicine that may help with the child's seizures. Epilepsy is frequently comorbid with autism spectrum disorder, and in that situation it may be that successful treatment of the epilepsy also leads to an improvement in development and sometimes an improvement in autism symptoms. But within autism spectrum disorder, we don't have great examples of that to date. There are two areas where we can expect that to improve over time. One is more likely to align with SPARC, where, for example, we have increasing knowledge that genetic conditions can dramatically increase risk of autism spectrum disorder, almost to the point of starting to talk about causes. So one of the examples of this is Fragile X syndrome, which we've known for a long time can lead to autism spectrum disorder in about a third of kids. But that means 2/3 don't have autism spectrum disorder, so you wouldn't say that it causes autism by itself. But in Fragile X syndrome, we have a lot of knowledge emerging from cell models and animal models that points us to potential treatments. And there have now been some large treatment studies. We don't yet have a treatment that is evidence-based, but a lot of good ideas that are continuing to be studied. Over time, we're seeing that 10, maybe now approaching 20% of kids with autism spectrum disorder have a genetic condition that largely significantly contributes to their autism. And in many of those cases, we may generate ideas from cell models and animal models, an understanding of neurobiology that's going to point us to treatment that is really based on the genetic finding. So that's one example, and that's where I think SPARC is really going to move things forward. I can't tell you which one of those genetic conditions is going to lead to a treatment first, but I can tell you this is an area of active and exciting work. The other domain is something that actually is already being marketed to families, and that is pharmacogenetics, where there are now tests that probably some of the folks in the audience have even seen done with their child that promise to give a profile of response to medicines. And that profile is based on two things. One is based on genetic variation in the proteins that are targeted by medicines. And thus far, there's absolutely no evidence that knowing that genetic profile will significantly improve outcome if you're prescribed a medicine related to one of those genetic findings. The other area is related to the metabolism of medicines. There too, there really isn't great evidence that knowing somebody's metabolic profile in advance will change their actual outcome when prescribed medicines. But those are tests that are not unreasonable to do after a child has been prescribed 2 or 3 medicines and hasn't had a good response, because it may indicate that a child's metabolism is responsible for their poor response or lack of response. So those are times to use those tests, but those are not things that I would do prior to prescribing a medicine in the first place. And by and large, I think that they're a waste of time and money. And sometimes they lead to not trying medicines that might be helpful because of a finding that doesn't make any sense. So why are they marketed? Why are these available? It's because there are different standards for testing than there are for actually prescribing medicines. And so the test is something that's allowed to be marketed, even though there isn't good evidence that it changes outcomes.
Okay. Can you speak about any treatments that have good evidence in successfully treating GI issues associated with autism?
So that's a great question and something that could be a whole nother talk. I actually took out some slides specifically related to GI or medical concerns that are frequent triggers for irritability and agitation symptoms. So the most common GI complaint that I see in autism spectrum disorder is constipation, and that can present in lots of different ways. One of the ways that can present is actually children who have difficulty achieving control over their bowels, so may not toilet train successfully, and sometimes in those kids what's occurring is that they, and forgive me, it's over the lunch hour, but that they have a little bit of leakage of stool around a really hard stool that is almost an obstruction. It's important for those kids who are usually quite uncomfortable and may have really embarrassing difficulties, sometimes embarrassing even for the family to talk about, like staining in the underwear, to adequately treat their constipation. Sometimes families aren't sure that constipation is the explanation, so oftentimes I'll, even as a child psychiatrist, try to work with the pediatrician to get an x-ray to evaluate whether their colon is actually full of stool. Where that's occurring, usually we start with something really straightforward, so sometimes that's even fiber supplementation, adding liquids, usually in young children, but then move appropriately up the chain, and so oftentimes that means sometimes pretty powerful laxatives, things like Miralax, and sometimes moving to things that are not just a laxative but also a stool stimulant. Usually at that point you want to work with a GI specialist, but typically the first couple of steps are things that can be done by a pediatrician, pediatric neurologist, sometimes a child psychiatrist. And I think it's really important to recognize and treat constipation. Also, I would say it's important to recognize that constipation can worsen during treatment with other medicines. So medicines like aripiprazole or risperidone are actually quite constipating, and it's important to recognize constipation as it's worsening. Sometimes the first sign is that kids aren't eating as well, even if they're not complaining that it's hurting. But these are things that we really need to pay attention to and treat.
Okay, we might have time for maybe 2 more questions. Do you have any evidence about long-term effects of medications on people with autism?
So that's a great question. So there are different types of evidence here. So one is looking at discontinuation trials, which is a way of evaluating whether a medicine is helpful as a maintenance treatment. And this is really a Food and Drug Administration definition, but essentially these 8-week sorts of trials are really quite common to see if a medicine is helpful in the first place, but obviously are short-term. There oftentimes is a long-term extension on those trials that may be another, say, 6 months, where some people are continued on the medicine and some people are randomized to go back to placebo. In those cases, we're able to see that risperidone is helpful as a maintenance treatment for 6 months, continues to lead to the same sorts of side effects. Aripiprazole actually has less data for maintenance treatment than risperidone. For the ADHD treatments I talked about, there really isn't great maintenance treatment evidence showing that it is helpful over the long term, but there is substantial evidence outside of autism spectrum disorder. So that's one domain. The other domain is looking at the sort of effects that emerge out of over time in people who are treated with these medicines. And the two things I'll talk about there, one is that people continue to gain weight on risperidone and aripiprazole and related medicines. And that's why the metformin results are so important. In that metformin study, most people had already been taking the medicines for 6 months, 12 months, maybe a couple years in cases. When people take those medicines, risperidone or aripiprazole, over the long term, there's an increased risk of obesity, there's an increased risk of diabetes-related lab findings, and there's an increased risk of diabetes. So we need to be really careful with those medicines and, where appropriate, reach for things like metformin to try to prevent that. You obviously can also do things by attempting to control diet. But those risks seem to be really tied to weight gain, but certainly are things that we're concerned about. The other thing that we know about from outside of the autism domain, and I should say that that data related to diabetes and risk of obesity is from the overall group of children and adolescents taking these medicines, not specifically ASD, but many of the kids in those analyses did have ASD, although not the majority from what I recall. The other thing of note is that stimulants lead to appetite suppression. So methylphenidate, anything related to amphetamines, leads to suppression of appetite. And when appetite is suppressed, obviously kids will fail to gain weight. Kids will sometimes fail to grow at the expected rate. So long-term treatment of stimulants has been shown obviously to lead to a decrease in weight gain, but also to lead to a decrease in growth. And that's something that's of a concern. If you can use medication holidays on the weekends or in the summer, the data show outside of the ASD population that you see a rebound in terms of weight gain and accompanying growth. But this is a conversation to have with a clinician. The decrease in growth, maybe that accounts for an inch, maybe a couple of inches over the sort of lifespan of childhood and adolescence. That's something to discuss and balance across the benefit a child is receiving from a medicine.
Okay. Well, we thank you so much for your time. This was a really great talk. I'm glad that you could answer some of our questions. That's unfortunately all the time that we have for today, but you gave an amazing presentation. We want to thank everyone that joined us. You can access a recording of this webinar soon on our website at www.sparkforautism.org. You can also learn more about the SPARK study and join online by visiting our website. Stay